Good afternoon, everyone, and welcome to today's special webinar on RSV. My name is Ian Colbert. I'm the Executive Director of the Canadian Public Health Association. I want to acknowledge that while we're coming together on this virtual platform from all parts of Turtle Island, I am joining from the ancestral and unceded territory of the Algonquin and Anishinaabe. I am very pleased that CPHA is able to bring this webinar to you in collaboration with the Ontario Public Health Association, and it has been supported through an unrestricted educational grant from Sanofi. Today's session is being recorded, and the recording, along with the presentations, will be available on CPHA's YouTube channel. And all registered delegates or registrants will be notified when the recording becomes available. So with that, I will turn it over to Kevin Churchill, President of the Ontario Public Health Association, to get things started. Kevin, the floor is yours.
Good afternoon. Thanks very much, Ian. My name is Kevin Churchill. I've worked in local public health for over 26 years. And for most of that time, I've been an active member of the Ontario Public Health Association. And I currently serve as the president of the board of the OPHA, and it's a privilege and an honor to do so. The OPHA is celebrating its 75th year, and our mission is to provide leadership on issues affecting the public's health and to strengthen the impact of people who are active in public and community health throughout Ontario. And by providing educational events like today's webinar is just one of the many ways that we execute this mission. And big disclaimer, I'm not an infectious disease specialist, but we're fortunate to have people on the call who are. I'd like to thank our speakers today, including Dr. Paul Roumeliotis and Fabiana Bacchini, who I will introduce properly as we proceed. I'd also like to thank Sanofi, as Ian mentioned, for sponsoring the webinar today. And finally, I'd like to thank and acknowledge Ian and the CPHA team for providing hosting and logistical support for today's event. As the Ontario Provincial Association representing the broader public health field, including those working on the front lines and people working in the community health sector, research, advocacy, and academic sectors, the OPHA's affiliation at the national level with the CPHA as a member of the Canadian Network of Public Health Associations is certainly one of our most long-standing and valued strategic relationships. Without further ado, it's my pleasure to introduce and welcome Fabiana Bacchini. Fabiana is the Executive Director of the Canadian Premature Babies Foundation, leading the organization in its mission to support and raise awareness about the challenges faced by premature infants and their families. Fabiana's journey began while she was in the neonatal intensive care unit with her surviving twin, who was born extremely preterm. She's collaborated in several research studies and is a published author of From Surviving to Thriving, A Mother's Journey Through Infertility, Loss, and Miracles. Welcome, Fabiana. Thank you.
Hi, Kevin. Thank you so much for having me here today and for the kind introduction. I'm just going to share my slides quickly. Here you go. So I'm very grateful for the opportunity to be here today to talk about RSV, as this topic is extremely relevant for our families, new families, in particular for families like mine who had preterm babies. This is my disclosure. So this is a little bit of my story. I delivered my twins at 26 weeks gestational age and spent 146 days in the neonatal intensive care unit, then ICU. My surviving twin Gabriel weighed 900 grams when he was born, weighs 2 pounds, had several infections and many complications because of prematurity. He was discharged in October, beginning of fall, still on home oxygen. Needless to say, I was scared, especially because I had a 3-year-old at home. He was in daycare, and I understood the risk of Gabriel getting sick. We had a lot of education sessions when you're in the ICU, so I really knew about the lung development and how at risk he was for getting an infection. I was very cautious coming home. Gabriel did receive his first dose of RSV prophylaxis just prior to discharge, and we had no visitors at home. I felt like COVID was already prepared for COVID because we were in totally isolation when he came home from the hospital. That was in 2012. But Gabriel still had many other respiratory infections that required many readmissions in his first 4 years of life. It was extremely stressful to be in the ICU with alarms and beeps all over again. And this photo was taken at SickKids Hospital, the pediatric intensive care unit, after Gabriel coded, and I had to do CPR on him on our small community hospital. So it was very, very scary. And that was his first Christmas, on Christmas Eve, in fact, when that happened. So needless to say, 11 years later, I still have PTSD. Every time I have to take him to emergency room with respiratory issues. So helping families of the most vulnerable babies really became my passion and what I've been doing for the last 11 years of my life. I ended up going back to Mount Sinai Hospital, where Gabriel was born, to become a volunteer in the ICU. And for the last 6 years, I've been leading the Canadian Premature Babies Foundation, which is a parent-led national organization supporting families of preterm babies. So our organization really work hard on education and support, as I mentioned. And one of the pillars, it is to educate families, because we believe that when you know better, you do better. Knowledge is power. So we really want families to know more about their baby, learn about their babies and the risk they face when they go home, so they can make better decisions that suit their families. But the hardest part of running a patient organization like ours is really to realize and understand the disparities in accessing care in many places, but also to access RSV prophylaxis for all our babies. Many families over the years have shared with us the burden of having their babies hospitalized and the long-term impact on their health. And here you can see some quotes of parents. You're going to have a copy of the slides that you can really understand what it meant to those families to be back. So having said that and knowing that, we decided to do a position paper back in 2022 calling for equal access for prophylaxis for all preterm babies, because we know the risks especially for the late preterm babies who have they don't fill the criteria, the current criteria to receive a prophylaxis, and those babies end up in hospitals. So we all know that when we launched that position paper, we all know what happened that winter. Hospitals are overwhelmed with babies admitted with RSV. And it was really a good time for our organization to raise awareness on RSV, but nothing really changed. So when the announcement by Health Canada last year on the approval of the new drug, we immediately launched a survey to learn about parents' understanding of the RSV risks and the uptake of a new drug. We learned a lot from this survey, and we identify a lot of gaps also that we could provide and fill in the system. So 99% of our families understood the risks of RSV, but keep in mind those families were all already discharged from the NICU. So most families received education in the NICUs when they are still in hospitals, but they still search for more information after discharge. So we create a lot of educational materials on RSV. We have this booklet that is free to download from our website that has a lot of other respiratory illnesses that families can face. And it's not only relevant for preterm babies, it's for all babies, including this infographic in 17 different languages. So we also learned that 24% of families were anxious about immunizing their preterm babies. And this is a very, very important piece of information, especially for people who work with our babies in the community. Families of preterm babies have a lot of trauma, and seeing their babies going through painful procedure add to their stress and anxiety, and a lot of families have fear of needles. So I think here there's a lot of opportunity for education, bringing a trauma-informed care approach. So we also ask families about their preferences and why they prefer one over the other, if it was available to them to have the option. We know that we want to have an option, but we really want to understand where they are coming from. Families still preferred palivizumab 54%, mainly because of safety and more interaction with healthcare providers. We did not have representation for families living in rural and remote areas, but we believe there is a lot of opportunity here for education and the need to bring evidence to the forefront for those families. And we want to provide your work. I feel there is a lot of synergies between the public health associations and the work that we do, because we do provide evidence-based education for families. And we want you to really support the families during this transition that might be happening in Canada over the next few years, to show families what is available to decrease the risk of their babies getting sick. And we are anxiously waiting for the Ontario announcements on the new criteria, because we don't want to leave any baby behind. We really want equal access to all babies, and we'll continue to bring the parents' voices and advocate for equal access to prophylaxis. And I will just leave with this quote that I believe we can accomplish much more when we work together and understand each other's perspectives. After all, we all here have the same goal: to see our little babies thrive. So, and here is my contact. If you need any material, you're always available to you. And thank you, Kevin.
Thank you so much, Fabiana. And next, it's my pleasure to introduce Dr. Paul Roumeliotis, somebody who will be known to many of you. And Dr. Paul is a highly respected pediatrician and the medical officer of health and chief executive officer of the Eastern Ontario Health Unit since 2007. Paul was director of continuing medical education in the Department of Pediatrics and founding director of multiformal health communications at McGill. Multi-format, sorry. Dr. Paul created and directed the Montreal Children's Hospital Asthma Center and Pediatric Consultation Center in 1990. He also holds a Master of Public Health MPH degree from the Johns Hopkins School of Public Health. In February 2018, Dr. Paul received the Canadian Certified Physician Executive Credential designation by the Canadian Society of Physician Leaders. Dr. Paul has achieved many more achievements and accolades, but in the interest of time, I will leave it there. Over to you, Dr. Paul.
Thank you. Thank you so much, Kevin. And I appreciate the invitation, and I appreciate the opportunity to talk about RSV. And it's a very, very good segue into the previous speaker, who I can really I can associate with. I understand very well, because as you know, I think I am the only pediatrician who's also a medical officer of health in Canada. And I'm going to be presenting to you. I'm going to just make sure I share my screen with you. Just here. Oh, and let's share. So you can see that, I guess. Okay, hold on. Going to go to the beginning. There we go. So, Kevin, you can see the slide full screen. I just want to make sure.
Yes.
Okay, thank you. So, you know, as I was saying before, I'm going to be giving you an update on, you know, recent advances in the prevention of RSV disease. I'll talk a bit about, you know, what RSV is, respiratory syncytial virus, what the impact is, and I'll both wearing my pediatrician hat, parent hat, and also, you know, medical officer of health in public health. You know, 15, 20 years ago, I was giving lectures on RSV. And before even, you know, the first prophylactic medication that was available back in 2007, before that, all we would do was just talk about, you know, treatment and management of RSV disease in sick babies. Right now, fortunately, as I'll talk to you about, there are some new things on the horizon that I'm very excited about, because I have seen firsthand both in the ICU, premature babies. Working up north, I've worked up north for a couple of months as well in Iqaluit. The impacts of RSV on young children and babies. And so it was, when Ian asked me to talk about this, I had no hesitation whatsoever, because again, I'm quite familiar with this, both from the pediatric point of view in terms of having treated babies, having seen babies, being admitted to the ICU, families suffer, and also recognizing right now that we've got some stuff we can do to prevent this very, very taxing. When I say taxing, I'm talking more on the families and the children. So the epidemiology and the burden of RSV, really, RSV is the most common single identifiable cause of lower respiratory tract infections in young children. In fact, all children by 2 years of age have been affected by RSV. It actually accounts for 80% of hospitalization for bronchiolitis and about 25% of pneumonia. And the risk of severe disease is higher in infants with certain medical conditions, including prematurity. And I will talk a bit about that later, just to list some of the children that are high risk. The highest incidence of the lower respiratory tract infection occurs in children between 2 and 6 months of age. And the risk of severe disease, obviously, and this is where we're seeing severe disease, is in infants. Obviously, all infants are prone to it, and I'll talk to you about it a bit later, but particularly children with comorbidities, lung issues, prematurity, and so on, that predisposes them to severe disease. However, during the RSV season of 2022, which I'll show you a graph on, the majority of infants who required medical office or emergency department visits had no underlying comorbidities or risk factors. So in fact, all babies less than 8 months of age are prone to this. Obviously, more severe disease in children who are born prematurely and or have other comorbid factors. And as many as 2.5% of all babies infected with RSV are admitted to hospital. And this is a graph that I took from the Public Health Agency of Canada, and it shows us normally what we see. This black dotted line is what we saw pre-pandemic. Typically, RSV starts around January, February, maybe December. It kind of peaks around January, February, March, and then it kind of goes away. What we saw in fall of 2022 that overwhelmed our hospitals, particularly pediatric hospitals, was an unprecedented kind of surge here of RSV early on that actually coincided at the same time as a flu surge. Again, both sort of came earlier than usual, and that's what happened. Ordinarily, however, last year we had more of a pattern of the pre-pandemic kind of seasonal. So you can see that it occurs primarily during the winter months, as do most respiratory viruses as well. So RSV really is it's an RNA virus, part of the paramyxovirus family, and it has a specific attachment proteins. These little attachment proteins kind of stick on to the respiratory epithelial cells and cause damage of those cells. And obviously, their target really is their lower bronchioles and lower lung parts, lower lung areas, the alveoli. But the transmission is important as well, because it occurs, it's like a cold really, or other respiratory illnesses, through hand contamination, self-inoculation, direct, spread, sneezing, coughing, and so on, and through it could rest for 24, 48 hours on furniture, keyboards, doorknobs, and so on. So it's kind of a typical type of respiratory tract virus transmission pattern that we see. So it is one of the most common causes of bronchiolitis. So very often although RSV is not synonymous with bronchiolitis, it is probably the most common cause of bronchiolitis. And what bronchiolitis is basically inflammation of the small bronchiole. So you have a bronchial tree, and then before it goes to the alveoli, the air sacs here, you kind of get a blockage here. And importantly, you can sort of imagine that in children who have underlying lung disease or who have prematurely formed lungs, this would become a bigger problem. And essentially, they're very small bronchioles, and so children by square foot area have more bronchioles. Actually, it has to do with square footage of the area. And if I give an example, if the airflow of a small bronchiole is reduced by half, it actually is a 16-fold increase in the resistance, in the airflow resistance. So you can see how easily these things can block. And so as children get older, they get less. They can get RSV, but not to the point where it'll cause such blocked bronchioles that give it such significant respiratory illness. And so, you know, in other lectures, I've talked about the pathophysiology in terms of how the cells are destroyed, and the fact that in premature infants or children who have underlying lung disease, that you can see where RSV can cause more significant and severe disease. So when we talk about severe disease, it really has to do with just beyond the sniffles and a cold, more to do with really when it gets down to the child having difficulty breathing, oxygenating themselves, and so on. And I will talk a bit about some of those symptoms. What is the outcome of an impact of RSV? We know in the short term, you know, in Canada, it's almost 6,000 hospitalizations every year with a mortality rate of 3 to 4%. And again, this is really among children who have severe confounding illnesses. The majority of older children who don't have underlying illnesses, when they get admitted to the hospital, are discharged. But the issue is when we're seeing more severe disease in these younger in these children who have these underlying confounding comorbidities and factors. Almost 70% of admissions are in children less than 2 years of age are attributed to RSV infection. And again, if you look at the cost of hospitalization for bronchiolitis in children, the taxing that it does on an already stressed, you know, overburdened healthcare system is quite significant, particularly when you're looking at children less than 1 year of age. Admission to hospital, you know, ICU, all of those things are very, very costly, and typically children stay in the hospital sometimes for weeks, you know, with a bronchiolitis, severe bronchiolitis, by the time they're well enough to go home. And obviously, this places a big strain on the healthcare system, but of course on the families of infected children. I've seen it so many times, and so I can empathize and really understand the stresses of having babies being intubated and so on. In the long term, this is something that I've been talking about since the 80s. You know, children hospitalized with bronchiolitis are more likely to have respiratory problems as older children, especially recurrent wheezing, compared to those who do not have the severe disease. And it's always kind of the chicken and egg, what came first? Is it the bronchiolitis that triggered an underlying kind of predilection to recurrent wheezing, or is it the child had a predisposed atopic tendency or allergic tendency that was triggered by the bronchiolitis? And we don't know, but we do know that there are some longer term sequelae for that. And obviously, the sicker a child is, the more the sequelae can be, both in the short term and in the long term. So talking about the infants at increased risk for severe disease, again, all infants are prone to this. Most infants by 2 years of age will have an infection, but the ones that end up in hospital during their first RSV season, obviously, are all premature babies, particularly born than 37 weeks gestation. Children with chronic lung disease. Most of the chronic lung disease occurs in premature babies that have had bronchopulmonary dysplasia due to, you know, respiratory being on a respirator for a while. Cystic fibrosis and other related issues, chronic cardiac disease is not stable, severe immunodeficiency, other congenital airway anomalies impairing clearing secretions. Because again, what happens is the sort of what we see with a typical RSV infection is that not only do you get you know, infection and plugging of those, the plugging is due to the secretions. There's a lot of abundance of inflammation that occurs, and then really children have a hard time clearing those. And if you combine the secretions in those small airways, you know, small little straw, put some jelly in there and compress it on top of it all, you can see that air can't pass. And that's what we really see. And neuromuscular diseases, again, children who have problems, myasthenia gravis and so on, who can't really clear their secretions. And again, those are the issues, and children with Down syndrome as well are more prone to that. And I put an asterisk here because we talked about the risk during the first season. Babies would also have, most of these babies here as well, with the exception of the premature babies would have a higher risk for their second season as well. And that's why and I'll show you later, there are some things that we can do even during the second season of a baby, particularly when they have underlying comorbidities and predisposition to severe disease. So there are also some associated risk factors as well, in addition to being the comorbid factors. Birth between April and September, that puts you at that sort of less than 8-month age group around the time when we see RSV infection. Daycare attendance, and again, the more people you're living with, crowded living conditions, again, the more exposure you have. These are things that I think people understand. Presence of school-age siblings at home that can bring home an infection. Prematurity, of course, multiple twins, again, multiple births, again, due to prematurity in most situations. Passive exposure, very important, passive exposure to cigarette smoke, male sex, and again, there's also an inequitable lens as well. Children coming from lower socioeconomic areas tend to have more RSV infections and complications. So the clinical presentation in terms of how they present, really, again, most children and older children more than 2 years of age will have like a runny nose, stuffy nose, cold, a bit of a cough, and that's it. However, in young children, obviously, and those are the ones that get in trouble, we can see, obviously, the runny nose, but tachypnea, which is rapid breathing, wheezing, cough, crackles, nasal flaring, chest wall retractions. These are all kind of clinical signs of a child having respiratory distress and not being able to breathe. Prolonged expiration, fever, of course, and apnea is actually another one. I have seen several babies who presented to hospital just being apneic, stop breathing. And we tested them and we observed them, and eventually they developed RSV, but it was pre wheezing and those retractions, and they just stopped breathing. And that's another, when we have babies who have apnea, we test them for RSV as well. Again, not all babies who have apnea have RSV, but we've seen apneic episodes as a precursor, actually, to the other clinical presentations that we see with RSV. So basically, these are kind of the symptoms. And as I said, the more you get down into the respiratory distress, we have categories, and we can sort of see, moderate, severe, based on retractions, O2 saturation, and all these things. And we can kind of judge, what children will need. Obviously, not feeding well is one of the most important ones as well. And even babies who don't have severe retractions or severe illness, but if they can't feed themselves, then they need to be admitted for IV hydration, for example. So those are the type of things that we look at. And again, the more severe the presentations, the more intense will be the treatment and support. And I'll talk a bit about that right now in terms of management of acute infection. And again, as I said, most babies will not require hospitalization, can be managed at home. But again, the ones that are admitted at the hospital, the management strategy will really depend on the clinical severity of the infection. And there's really no specific treatment. And that's the other thing too. There's no specific treatment for this. And so the treatment really is supportive, providing oxygen, O2 saturation, bronchodilator use, corticosteroids. Antivirals, again, in very certain situations, we have something called ribavirin, but that's very rare, aerosolized. We don't use it a lot. And then hydration. And obviously, in worst case scenarios, intubation and being put on a respirator because the child can't really support breathing on their own. Sometimes we may do some suctioning and so on, but that's not really what we're doing for the most part. We try to help kids clear the secretions, but again, these are the mainstays. But as you could see, there really isn't a specific approach. So all the more reason to look at preventative strategies. And as I said, as we said, up until recently, and I'll talk about it, there hasn't been that much more available for many babies. That's been practical, and I will talk about that soon. But let me just sort of talk about sort of the mainstays now of RSV prevention. And I remember I did an educational program back when palivizumab or Synagis was launched in 2006, 2007. And at that point, I talked about the two mainstays of prevention. because again, the lack of treatment and the severe disease and burden that it causes on our healthcare system, but importantly on the families of these children. So hygiene and infection control and prevention, and then pre-exposure immunization. And back then there was one product called perlivizumab that was limited in terms of who was given to. It was quite expensive, and it had to be given monthly because it didn't last more than a month. And so it was a bit impractical, but we do have some good news coming up. But before I talk about that, I will just sort of summarize some of the hygiene and infection control and prevention, which we're all familiar with, particularly with COVID, that we've been talking a lot about that. So obviously the infection control and prevention measures, frequent hand washing, disinfection of common surfaces, avoiding crowds, avoiding persons with colds, avoiding passive smoke, and avoiding daycare if possible. Again, sometimes that's not possible, but again, these are the things that we have. And really, up until recently, we didn't have anything that can sort of cover all children other than these things, except for that perlivizumab that was really restricted in terms of its ability to protect for a long time, and it was actually limited in terms of scope of who was getting it. And so right now, there are 2 products approved in Canada for the prevention of RSV infection in young children. And one is, I always have a problem pronouncing it, nirsevimab, which is a monoclonal antibody, and it's passive immunization. So let me take a second just to sort of clarify passive immunization versus active immunization. So when we talk about passive immunization, it's kind of the first immunization, if you like, back in the 1900s, where they took horse serum of horses infected with diphtheria, if I'm not mistaken, and basically they extracted the serum, which had antibodies already against the diphtheria, I think it was at that time, and they injected it to humans. And what they did is they were actually injecting antibodies that gave them some protection against diphtheria. Back in those days, in tetanus, I think it was, but I think it was diphtheria initially. And so that is a passive. So nirsevimab is really a modern version of that, but it's laboratory. It's a monoclonal antibody that I'll talk a bit about later, but that's a passive immunization that's given to babies, and it protects them for at least 180 days, 6 months worth. So that again is new, and I will talk a bit more about that later. The other one that's out there is the RSV Pre-F vaccine. It's basically a vaccine that's been authorized to protect infants in their first RSV season through passive transfer. And this is a combination, active and passive. So basically this is vaccinating the pregnant mother, the pregnant parent, and that the mother will develop antibodies, and that's active immunization. So most of our immunizations are active, and we actually inject all the routine vaccines and so on. We inject antigen or partially alive or fully killed parts of the virus or bacteria, and then our body produces antibodies. So our antibodies and our immune response is generated through an active mechanism, and so that occurs in the mother, but the antibodies are then transferred to the baby through the placenta. But the baby gets it passively, similar to, gets the antibodies that are already made actively by the mother into the baby, and it can also protect the baby as well. And so those are the 2 new things that have come out. And I'll start with nirsevimab first. Basically, it's a monoclonal antibody, and basically what it does is basically we inject it, and that sort of these red things are the antibodies that actually coat and then block those the virus and fully block it, and that virus can't attach to the epithelial cells in the respiratory system, in the respiratory tract, and therefore prevent disease. And that's really the bottom line. And again, this is a sort of a passive approach. So it's not technically a vaccine per se. But it works to protect. So these are both pre-exposure immunization. In other words, before the baby is exposed, we immunize them. And in this situation, we actually give them passive antibodies that will last in their body for at least 6 months, 180 days, to be able to protect them from RSV during the upcoming RSV season. So again, game changer to me, a very important sort of way of preventing it. The other product was out there, was similar, but was not as effective and didn't last as long as this one. And sort of, I'll give you a bit of, this is a lot here, but it's going to be on my slides as well. But it's really it's supplied, and depending on it's a pre-filled syringes, 50 milligram or 100 milligram, and it depends on the age. It's given IM. Again, depending on what their weight and their height and so on, their weight, not height, but their weight, it's either the 50 milligram dose or the 100 milligram dose. And again, for children who remain vulnerable, there's a second dose for the second season. Remember, I talked about the second season vulnerability up to 2 years of age, and there are different dosages and different modalities given at that age group. But again, for the most part, this is one shot that's given. It's not different from our other vaccines. It should be maintained at 2 to 8 degrees, shouldn't be frozen. If you remove it from the fridge, it may be kept at room temperature for a maximum of 8 hours. Other than that, you just discard it. So it's very easy it's not like the original Pfizer, COVID vaccine, if you recall. So it's quite easy. And importantly, it can be administered on the same day or any time before or after routine vaccine. So it could be co-administered. Ideally, I'd like it to be administered at birth, at the hospital, and I will talk a bit about that later when I talk about some of the NACI recommendations. The other product is the RSV, and again, this is supplied, the RSV prenatal vaccination, and that's given to pregnant mothers between 32 and 36 weeks gestation, 1 dose IM. These come in it has to be reconstituted. Again, not dissimilar to other vaccines, it needs to be refrigerated at 2 to 8 degrees, not frozen, and so on. And it's got a limited kind of shelf life after 4 hours of reconstitution. Now, in terms of co-administration here, it can be, the studies have shown that it can be given, data has been shown that it can be given concurrently with other vaccines, DTaP, for example. As you know, we give pertussis a booster to every pregnant mother during every pregnancy, and flu shots as well. But there's no other studies on how co-administering with others. I have a bit of a sort of not a reservation on this, but I think this is a vaccine. This vaccine theoretically, I think it works. It hasn't been shown to be as effective in terms of protecting the baby in terms of duration. And I also think that mothers in particular, going back to some of the I think Fabienne talked about in terms of hesitancy, many vaccines and so on. We're proposing to mothers during pregnancy that they need the DPT, they need the flu shot, they need the COVID shot because they're at high risk for the complications of those. And now we're giving them a 4th one. So I don't know what the pickup will be of that, but that is available as well. And I think it will be covered at one point in Ontario as well. However, the NACI recommendations have specific recommendations when it comes to that. So I want to spend some time on the NACI recommendations. As you know, the National Advisory of Immunization Committee on Immunization is the one working with PHAC that sets out recommendations, evidence-based recommendations on new vaccinations that come out, and basically they study what's coming out and create kind of recommendations, and then individual provinces use NACI to back their policy decisions. So what NACI, this is kind of from the NACI summaries. I took some almost word for word. But it's very clear. The receipt of a single dose of nirsevimab was highly effective against RSV-associated hospitalization in infants entering their 1st season, up to 80%, 81%. In some countries, it's higher. I know there's been experience around the world, UK, Spain, that have had very good success with this. It is actually preferred over RSV prenatal vaccination because of the duration of protection. The prenatal one for mothers can be considered on an individual level, but it's not recommended as an immunization program. And so, NACI, after considering the significant burden of the disease in all infants for RSV and the impacts of RSV on the Canadian health system, their recommendation is to build a universal RSV immunization program for all infants with nirsevimab. And I do know that, some provinces are looking at it. I know that Quebec is actually going with this, and I think other provinces will follow suit. Hopefully, we'll have some news on that, in the next month or so. And I think with the goal of the universal, so this is basically protecting all babies, essentially. A baby, and this is what the sort of the more specific in terms of the NACI recommendation, which was really looking at, protecting all infants, any infants less than eight months of age, entering or born during their first season, infants entering or in their second season. Again, this is what I talked about, those higher risk babies in their second year, getting a second dose of it, and to prioritize this for certain populations, seeing that it's cost effective. And so I do believe that, rolling this out, making it available for all, all babies less than eight months of age, of course, will blanket cover everybody. Of course, at the same time, it'll protect the higher risk babies as well, because that's what we're going to be, concentrating on those and concentrating on giving them a second dose the second year as well. But this is going to really, I think, make a big dent if it's applied this as the way that NACI recommends it, and I'm hoping that Ontario and other provinces will follow suit as well. And again, they talked about RSV, the prenatal one not being required if you're going to give the child, at birth. And so this is, I think this is good news. We've had, sort of my concluding thoughts really is, this is good news to me, good news to the families, good news to the healthcare system, because this is one of the diseases that I've been frustrated with. When I started in pediatrics, Haemophilus influenza bacteria was rampant. I would be seeing 20, 30 kids a week with meningitis, epiglottitis, arthritis, you name it. And with the advent of Haemophilus influenza vaccination, nobody has seen that. Pneumococcus, the same. We had a lot of pneumococcal disease had occurred in babies, despite that these were bacteria, and despite the fact that we had antibiotics. It really caused severe morbidity, mortality after Haemophilus influenza was controlled. Pneumococcus became the most common cause of meningitis and severe complications. And thanks to vaccines, we're seeing a much decreased burden of those diseases. And what was left really was RSV. Those are the top things that we would be seeing in hospitals, particularly during the winter months. And so, recognizing that, it's a significant issue on the young children and the burden on the healthcare system and the social and stressful toll that it takes on families. I think this is important for us to understand and to understand what we're trying to prevent. Again, just to, certain babies are at higher risk and there is no effective treatment. And when I say higher risk for severe infections, although, like I said, most of the admissions, most of the babies that were admitted were not at really high risk. However, we do see that certain babies do have a much higher risk for complications. And up until now, there really was no available universal prevention tool. The palivizumab was for selected populations and had limited applicability because it was expensive and had to be given monthly. And so that was a bit impractical. Now we have effective and safe, again, the safety of both of the products that I mentioned, but particularly nirsevimab, there's really minimal, if any, side effects. There's no interaction with other vaccines. And so I really believe that this is going to be, a game changer as far as I'm concerned. A universal pre-exposure monoclonal antibody that's passively given to all babies, whether it's in hospital, whether it's, at clinics and public health or whatever, I think will be a real game changer as we move forward. And finally, we'll have another way that we can prevent this potentially very serious illness in children. And so, one of the things that we'll be looking at, and I as a public health leader have been sort of pondering and looking at, and discussing with the ministry and other colleagues, is how are we going to be rolling this out? What are the logistics? So I think that, health authorities across Canada are now looking at, as we're looking at, are we going to implement this? Are we going to follow NACI recommendations? And if we do follow the NACI recommendations, which is kind of a universal program for all babies less than 8 months of age, how do we do that? How do we work, for example, in the Ontario setting? How do we work, in the hospital with, OBGYNs, with OBGYN departments? Can we give it at the same time as we're giving vitamin K, for example? We're getting an injection anyway at birth. Can we give it at birth? Who will give it at birth? The OBGYN nurses can do that. Midwives, we're also working, hoping that they can get approval for that, because it's not considered a vaccine, but I do believe that there might be some change in the regulation. And then what happens, when babies are discharged, or babies who were born after, with the availability of it was after they were born, how do we catch up? And so those are the type of, will public health do it? Will pediatrics do it? Will family health, family doctors do it? And again, we have to really be thinking about this, because the more we think about these challenges, and some of them are more local than others, like in our area, in the Eastern Ontario Health Unit area, we don't have a lot of primary care, and a lot of well, baby care is delivered through our health unit. So we've got to look at ways of how we can then participate in that. I do know that if it likely, when it does become available in Ontario, if it becomes a universal program, that it'll be distributed through public health. But again, we really have to think about it, because we got a great medication. If we can't get it into the babies, it's not going to work, right? So we need to think about it and prepare ahead of time. So if you're in other jurisdictions, other provinces, chances are that perhaps, again, Quebec has gone on it. Ontario, we're hoping will. And at some point, we need to have those logistics ready to go. So we'll have an effective universal campaign. If it's not universal, it's not going to give, the more babies we vaccinate, the more we're going to prevent those babies from becoming sick, and obviously the more relief that we will be providing the hospitals. And so it's a win-win for everybody, and I'm so grateful that we have these available to us. Again, I urge everybody out there to be familiar with this, and to spread the word. I'm working with Immunize Canada as well. We're doing a lot of education, national education, for parents to know what RSV is, to understand the complications of RSV, to understand, yes, there are high-risk babies, and for those that they particularly need it, but also any young baby 8 months of age can be at risk for infection and requiring hospitalization. And so we need to make people understand what RSV is, what the repercussions are, and what we can do to prevent it. And I think that's our challenge as we move forward to launch this new exciting approach to what was once something that we couldn't prevent and we couldn't even treat. So that's it for me, Kevin. I will be happy to answer questions. Again, you can see that I'm excited about it, because I've actually had to resuscitate babies. I've had to, tell parents of the babies in the ICU with this, and I do recognize the burden that it takes, on these little babies, long-term consequences on the babies, and the effect that it has on their families, and of course, our healthcare system.
Thanks so much, Dr. Paul, for sharing your extensive knowledge and this information with our audience today. And we do have a couple of questions in the chat, so we'll spend the next little bit of time. I'll pose those questions to you as they come. Sure. And first question is, what are your thoughts of using racemic epinephrine and Ventolin puffers?
That was one of the mainstays of our treatment in the absence of anything else. We would be using Ventolin and/or racemic epinephrine. Racemic epinephrine, we'd use it more for laryngeal laryngitis, stridor, those type of things. But certainly in terms of Ventolin puffers or Ventolin, when the child is wheezing, it is effective to the point where some of them we also give them corticosteroids. As you know, that we also treat acute asthma as corticosteroids. So it's not dissimilar to the treatment, and that's one of the things that we would be recommending as well if the child has wheezing and/or other difficulties. Obviously, if you give it a Ventolin puffer for home, you got to monitor it to make sure the parents are administering it properly, and then it's doing its job, because the child may still need to be admitted. It might be easier to give it through a nebulizer in the hospital.
Okay, thanks for that. The next question, Natalie asks, would you give the RSV pre-F to mom and then Diversimed to baby once born, or is it one or the other? I think you may have answered this.
You know what? That's a good question. You could probably not go wrong with giving it both, but the recommendation is just to give it to the baby, and it wouldn't be necessary otherwise. So that's really that's what the NACI recommendation is. But those are individual ones. You won't be wrong. You won't be wrong by doing it, but practically speaking, one or the other, and we prefer you're giving it to the baby actually, because it's going to give longer protection.
Okay. Thanks for that. There's a it's not necessarily a question, but a comment from Paul. Pregnant women also need Bordetella pertussis
yes,
shots.
DPT,
So,
yeah, DT.
yeah.
That's the one I mentioned. That's
Okay.
one of the ones. So you need that. You need that at every pregnancy, COVID and influenza. So that's three, and now you're adding a fourth. And that was my hesitation in terms of trying to put myself in the position of a mother. As you know, a lot of people are questioning vaccines and so on. You know, so that's why I thought maybe it would be, giving it to the baby would be less of a stress on the parents. But again, it's a discussion that we need to have, and that's what we need to educate them.
Okay. We've got one more question that's come in on the chat from Mai. Are those with births between April and September more at risk of RSV due to their birth relative to the first respiratory season? Or is it a lifetime higher risk for anyone of any age born between April and September?
No, it's just that they happen to be born around the time where if they're still going to be during the first year at a very vulnerable age when we have a northern hemisphere flu respiratory season, which typically is November, December, January. So that puts them there. It's not in Australia, it's kind of the opposite. RSV occurs during flu season, which occurs in our summer and spring. Yeah. So it's just the opposite.
Yeah. And to be fair to the person that asked the question, she did put in that in the northern hemisphere. Yeah. I just left that piece out. Yeah. Okay. So I don't see any other questions. So I'd just like to thank you once again, Paul and Fabiana, for speaking and spending your time with us today. And we're looking forward to hearing more about this as the news and things emerge. But with that, I will turn it over to Ian just to wrap up.
Thank you so much, Kevin. And a big thank you to all of our speakers. That has been a tremendous presentation today. And I think that I need to do something here. There we go. We can see everyone now. Thank you all to our speakers. Thank you to everyone who participated in the webinar. As I mentioned before, the recording and the presentations will be available on CPHA's YouTube channel. All registrants will be notified when it is available. And final thanks to Sanofi for providing an unrestricted educational grant to support today's webinar. Thank you all very much. Have a great day.